So, guys, now I have already presented you to the basics of ECG. Now, coming to the what are the abnormal ECG findings you should encounter. So, what is ECG? I have already mentioned in my previous presentation. So, just I will not go through any of this. We'll come through. Start with. So normal ECG reminder, you already know that what is PR interval, PR segment, QRS complex, what is ST segment, and what is QT interval. So PR interval is normal 3 to 5 small square, QRS is less than 3 small square, ST segment less than 2 small square, QT interval is less than 2 large square. This is the normal interval. Now, coming to the best way to interpretation is rate, rhythm, axis, P wave, PR interval, QRS complex, ST segment, QT interval, including T and U wave, and other ECG signs. Now coming to rate, how to calculate rate. Rate is equal to 300 by the number of big square between RR interval, or 1500 by the number of small square between RR interval. So calculating rate, suppose this is 15 small square, 1500 by 15 is 100, or 3 large square, that is 300 by 3 is 100 beat per minute. Now, if you think that the rhythm is not regular, then count the number of electrical beats in a 6-second strip and multiply that number by 10, and that is number of wave. Look at this strip. 1 second is, you can easily calculate. So use 6 seconds. 1, 2, 3, 4, 5, 6, 7, 8. 8 into 10, that is 80 beat per minute. Also, you can go for any 10-second strip and multiply by 6. 6-second strip multiply by 10, or 10-second strip multiply by 6. Now, look at this rate. I will not go in details into it. You just, when you will see the video, you just pause it and write down the causes of normal bradycardia, tachycardia. Brady is less than 60, tachy is less than 100. The causes, you can easily write it down from here. Rhythm. Look at the P wave and the responses to QRS complex usually lead to, is commonly used for rhythm. Regular or irregular, you have to see. If you are having some doubt, use a paper strip to map out the consecutive beat. Like, take a paper and use this consecutive beat pen line and see whether the rate is same along the all. First, give a normal looking to RR interval, then shift to this, and check whether all QRS beat are getting in line with these two marking. So it can also by atrial rate rhythm can also be monitored by using PP interval. The normal sinus rhythm is rate between 60 to 99. Every P wave must be followed by QRS, and every QRS should be preceded by P wave. Normal duration of PR interval is 3 to 5 small square. The P wave is upright in lead 1 and 2. I have already mentioned all these things in my previous normal basics of ECG presentation. Sinus bradycardia, you can easily calculate that the rate is less than 60. What is the small number of big square? 1, 2, 3, 4, 5, 6, 7, 8. So 300 by 8 almost. So it can go only around less than 40. The heart rate is here. Sinus tachycardia pulse rate is more than 100, otherwise normal. What is sinus pause? That is, sinus node is diseased, known as the SA node 6 sinus syndrome. The SA node can fail in pacing function, and so but it is brief and recovery can be done easily, and it is a missed bit. Like, look at this, it occurring regularly. Suddenly here there is no P wave, no QRS. Means the SA node does not generate any atrial deprivation, so heart pauses for a minute, then again continues into the normal function. So this is known as sinus pause. Atrial fibrillation, where there is no fixed P wave and atria has been depolarized by multiple foci, so that multiple area is activating the atrial rate. Cardiac arrhythmia involving atrial rate is usually more than 150 per minute. It is irregular. Baseline, you can see that the baseline is irregular. No visible definite P wave is there. and QRS occurs also irregularly, with the length is usually less than 3 small square. Atrial flutter here, you can see that the korater moto a sawtooth appearance. Here you can see that there is sawtooth appearance. Basic mechanism is macro re-entry, which is difficult to understand for you guys. So I will not go into this details, but you can just show that they have flutter waves. There is like korater দাঁত বা হাঙরের দাঁত যদি বলা হয়, is sawtooth appearance. It occurs usually with atrioventricular fixed block, so that you can see that every 3 flutter waves there is only one QRS complex. For sinus rhythm there is a one sinus P and then another QRS, one P, another QRS. But here you can see that 3 atrial complex followed by a QRS. So 3:1 block is there with atrial flutter. Ventricular fibrillation, you can easily understand, this is a basic life-threatening fibrillation, a severely abnormal heart rhythm. That you cannot recognize any particular rhythm. Look at the ECG. The ECG is not recognizable. No definite pattern is followed. So it is known as ventricular fibrillation. And ventricular tachycardia. Here, what occurs? It is maybe regular or irregular, but mostly regular, and it is originates from the ventricle. But it is leads to ventricular fibrillation. So it can go to this from this. Okay. And this is torsades pointis. Here you can see that there is twisting of points. That is around the baseline, it is increasing in amplitude, then again decreasing, then increasing again, then decreasing, then increasing. So this type of known as the polymorphic ventricular tachycardia. So it is mostly electrolyte imbalance, occurs due to mostly electrolyte imbalance, and it twisting of the QRS complex along the isoelectric line. So this isoelectric, around this isoelectric line, amplitude increases, then decreases, increases, then decreases. So it is very easy to recognize. Supraventricular tachycardia. Here, supraventricular tachycardia, the most important thing is that there will be tachycardia. The QRS complex will be narrow. Look at this. The QRS complex is very narrow, and there is rate is more than 150 up to 250 can be there. P wave is usually not visible. If it can be visible, but just remember that usually if you tell in the exam, or if you know that Q wave is usually not visible, QRS complex is narrow, and tachycardia is there. There's various multiple types. I will not go into details of that, but causes are there. You can note down easily what are the types of supraventricular tachycardia. Atrial escape when there is a suppression of sinus impulse formation. So atrial escape, sinus beat, they fail to materialize. So then atrial, other atrial focus, that is, look at the P wave morphology. So here up to this is sinus normal pure, but from here onward you can see that the P wave morphology has been changed. So the other foci act as a cardiac pacemaker. So P wave atrial escape is called atrial escape rhythm. Junctional escape also similarly, junctional escape P wave is usually not visible, but it is regular QRS complex. For atrial fibrillation, P wave is not visible, but this is irregular. But in junctional escape, P wave is usually not visible, can be visible also. Rate decreases from the normal rate 40 to 60 rate. This is junctional escape rate. Ventricular escape, always remember any complex arising from the ventricle will be wide. This is the difference between supraventricular. Any supraventricular will be, QRS will be narrow, but in ventricular, look at this wide. This is narrow complex. So the origination of this impulse is P wave from the supraventricle, that is above the ventricle, from atrium. So for in this case, you can see that no P wave is visible, but P wave can be visible. It is retrograde, can be visible, but usually no P wave visible, and it is wide complex. So it is ventricular escape. Atrial premature beat, that is arises from then other focus than the SA node. So you can see that SA node, suddenly the P wave morphology has been changed, and then again sinus node resets, again the sinus. So this is atrial premature beat. Junctional premature beat also. Junctional premature also in AV junction. It is. I am not going to detail. Usually need not to know all these things. Premature ventricular complex. You should know there is VPC. Sometimes patient complains of palpitation, chest discomfort, occasional sensation of the heart beat. So here normal, suddenly and wide complex. Always remember the ventricular complex are wide, then again there is no such activity again after some times, again sinus no sinus no. So this is premature ventricular complex. Asystole, as after death usually occurs, no electrical activity, straight line. Pulsed electrical activity, it is not an, because the myocardial muscle activity is there, but there will be no pulse. Occurs usually, patient is usually clinically dead. Now pacemaker ECG. No, this spike is you are seeing before every QRS. That is the pulse of generated by activity generated by pacemaker activity. This is POA, maybe absent, maybe present, but this spike will be there. It depends on the whether it is single chamber or dual chamber. In single chamber there will be single spike, dual chamber there will be two spike. Now cardiac axis, how to determine axis I have already mentioned, so I will, you just remember that in positive axis we have seen the lead 1 is usually positive, and lead this is normal axis, lead 1 positive, AVF positive. In this case all these three will be positive, so predominantly positive from this time. Negative axis you can see, negative left axis you can see that AVF is down, A is negative axis, also lead 2 3 will be negative. And for right axis deviation, lead 1 will be negative mostly, and AVF will be positive. Also lead 2 and 3 will be positive. So note down the causes. I will not describe all these things. You have to just know the causes in which condition left axis, right axis deviation, and northwest. Northwest means that is indeterminate axis. That is from minus 90 to 360 or minus 180 degree, and this is known as northwest or indeterminate axis. Now for POA morphology, we all know it is a 3 small square length less than and 2 small square in height. It will be always positive in lead 1 and 2 in sinus rhythm, always a negative in AVR in sinus rhythm, commonly biphagic in lead 1. So for P pulmonally, it is this is P pulmonally tall peak due to enlarged right atrium, biphagic TOM in V1. It is occurs in left atrial enlargement. P mitrally, that is notch in bifid. This is known as the mitral stenosis or left atrial enlargement. It can occur. For PR interval, we all know PR interval normal duration 3 to 5 small square, 1 to 200 millisecond. Long PR interval indicate a heart block. Short PR interval is like WPW syndrome. Now for first degree AV block, the first degree AV block simply is that the PR interval is more than 5 small square. If you look at this PR interval, starting up from the P and up to R is more than 5 small square, more than 5 small square, more than 5 small square, more than 5 small square. So, but it remains constant every bit. So this is the first degree heart block. For second degree heart block, there is two types: Mobich type 1 or Mobich type 2. Now, kindly look in this ECG. Look at the first PR interval. It is then second, then third. What is the interpretation? It is small, it is slightly larger, it is more larger. So gradually there is increasing of the PR interval. Suddenly we find that there is only one POA, but there is no QRS complex. Then QRS complex got blocked. Again, look at this small increasing, further increasing. Okay? So this kind of ECG is known as the Winky back type, Mobich type 1. For Mobich type 2, you can see that there is a fixed relation, so that the PR interval is constant. Look at the PR interval in every bit constant, but there is one bit that is not transmitting. So this POA is not transmitting. This POA, there is PR interval is always constant in Mobich type. It can be 2 POF, 3 POF, and only one is conducting. That will be 3:1. Or 3 POF, there are 2 is conducting, 3:2 block. So here it is 2:1. 2 POF, 1 is conducting. 2 POF, 1 is conducting. 2:1 block. Now, third degree heart block is simply complete heart block. What we have noticed that there will be no relation between the P and R, but the P and PP interval and RR interval will be remain constant. Look at this interval. Here POF, this POF, this is the interval. Look at the PP interval. This is POF. Okay, this is POF. This is again POF. This is again POF. So all these POF are constant. QRS, you look at this, QRS is constant. QRS is constant. QRS is constant. But if you gradually look at the PR interval is not constant. Here it is larger. Here it is smaller. Here it is very small. But the PP interval and RR interval are constant. So this is known as the third degree block or complete heart block. Now coming to WPW syndrome. WPW syndrome is a type accessory bundle of current is there, so that the pulse that is generated by the SA node goes rapidly bypassing the AV node. So this is interesting is that the short PR interval and delta wave. This is very much what is the early activity. The PR interval is short, and this is this normally what happens. There is straight ROA, but here there is a hump. This is sluggishly it has been ranged, then goes straight. So this is known as the delta wave, and the PR interval is short. So this is known as the WPW syndrome. Now coming to QRS complex. So QRS complex, normal length is less than 3 small square, less than 0.110, and normal Q wave amplitude is less than 1/3 of the QRS amplitude. So this is the amplitude of Q wave. From this point to this point, this height is the amplitude. It will be less. Normally, it will be less than 1/3 of the QRS amplitude. QRS amplitude from the R wave to the S wave. This wave. So এর থেকে এটা 3 গুণ কম ছোট হতে হবে, ঠিক আছে? So this is the normal. Now coming to QRS complex left bundle branch block. Left bundle branch block, you can see that what is happens in left bundle branch block you have to look for V6 and V1. So there will be in V6 the complex will be M separate. Look at this. This is M separate, and in V1 it will be like W separate. Okay, W separate. This is M separate, and for RBB you can see that there will be the notch M separate type in V1, but V6 there will be no notch like M separate in V6. So the V6 will be M separate. That is called RSR pattern. It will seen in V6 in case of V5 V6 in BAB, or in V1 it is RBAB. This is R, this is S, and this is R1. This is RSR pattern is in V1. Now ST segment. This ST segment is the isoelectric line at the same level as subsequent PR interval. That is the S and T segment. This is on the ST segment. It is usually less than 2 to 3 small square. Usually less than 80 to 120 millisecond. Now, what is the important thing we have to know for ST segment is that ST segment elevation MI and non-ST segment elevation MI. So normally the ST segment line is flat. Elevation or depression or the ST segment by 1 millimeter or more is measured at J point is abnormal. J point we already discussed in the previous presentation. This is the junction between the S end of the S wave and start of the ST segment. J point between the QRS and the ST segment. So this is elevation of J point is important. So you can localize also by looking at the ST segment elevation. Now first I go through the ST segment elevation. Now look at this. This is the baseline point of the PR segment. That is baseline, but this J point is elevated further. So for that elevation you have to know for limb leads. That is lead 1, 2, 3. In this limb lead there will be 1 millimeter elevation, and for chest lead, that is V1 to V6, there will be 2 millimeter of elevation should be there, and Q wave should be more than 1 small square. So this is known as the ST segment elevation. And also the pathological Q wave, that is signs of previous myocardial infarction. In pathological Q wave, I already told that the pathological Q wave should be less than 1/3 of the QRS complex height. If it is more than 1/3 of the QRS complex, and also it is more than 1 small square in amplitude, then it is known as the pathological Q wave. Now coming to the ST segment elevation, how to localize an MI. If the ST segment, you can see the chart that you have to look for the ST segment elevation in this lead. For anterior location of MI, V1, V2, V3, V4, location of the arteries LED. Septum, V1, V2, LED. Left lateral MI, 1 AVL, V5, V6. Left circumflex. Inferior 2, 3 AVF, RCA. Right atrium, AVR, V1, RCA. Posterior chest is like V8, V9, V10, involvement RCA. Right ventricle, right sided leads RV3, RV2, RV4, and all this involvement of RCA. So you need to look for the certain areas of the ECG in which you can find easily which segment of the artery has been involved in the MI. Now, a segment elevation changes in MI. That is in initial period, the hyperacute, that is ST segment highly elevated, and convex elevation. You look at the elevation, that is convexity is there. convexity is there. After 21 to 24 hours, now R wave is slightly decreased, with T wave becoming they had the T wave is smooth, but they had the becoming tall and peaked. Gradually, there is development of Q wave, and the T wave starting to decrease, inverted, and then gradually these ST segments settle down. Q wave becomes inverted. Q wave is there. In long-standing region, only Q wave is the presentation, but the T wave may go to return to normal. This is the ECG changes of MI. Now, ST segment elevation, you can see that the here the ECG, you can see there is more than 2 millimeter elevation, 2 millimeter elevation. V2, V3 is involved. I already mentioned V2, V3 involvement is there. There is also V4 involvement. It is an anterolateral MI. There you can see, you can tell easily that you can see that the ST segment is elevated in 2 and 3 and AVF. So it is an inferior wall MI. So what is end STEMI? In end STEMI, there is no ST elevation, but instead there is a ST depression. So to confirm the end STEMI, we have to do a troponin test. If the troponin test is positive, then we have to do term it as end STEMI. If it is negative, then unstable angina. So it is, there is ACS patient comes with chest pain. There is no ST elevation, but the ST segment is usually depressed. TOF is usually inverted. Sometimes TOF may be inverted without ST segment is depression. Q wave and ST segment elevation usually not a feature of end STEMI or ACS. Now look at this, because here the ST segment is T wave is depressed, patient with troponin is positive, ischemic changes is there, T wave is inverted, so it is an end STEMI. And also now this patient ST segment is depressed, so myocardial ischemia is there, no ST segment elevation. Now pericarditis also is a cause of ST segment elevation, but one of the important things to differentiate between the thing is that the ST segment elevation concavity is upward. For this MI, you have seen that the ST segment elevation, what is there is convexity upwards, but in case of pericarditis, the ST segment elevated, but the upper part is concave. This is concave, not convex. Convex is there, then it is MI. Other features of pericarditis also has to be noted that the most important PR segment depression, but I will not go in detail. So you have to just know that the ST segment is concave upwards in case of pericarditis. Now LVH, you have to know what is LVH, what is RVH. Now there is a criteria. আমাদের দেখতে হবে S in V1. In V1, what is the S amplitude or R wave in V5, V6? It is more than 35 millimeter, 35 small square, then it is called LVH. There is a criteria which is written. Jodi AVL jodi R is more than 14 millimeter, then it also LVH. Or sometimes V3 in S in V3 or R in AVL is more than 29 millimeter. It is known as the LVH. We note down all this criteria. It is known as Cornell criteria. This S in V3 and R in AVL. Sokolo-Leon is S in V1, R in V5, V6 more than 35 millimeter. So it is called LVH, and this is, you can see that LVH is koto boro ekhane V1 e ekhane V5 V6 e R boro, and there will be T wave inverted in it is known as the strain pattern. LVH with strain. For RVH, there should be right axis. You look at that, it is right axis, negative in predominantly negative in lead 1 and predominantly positive in lead AVF. So it is a right axis deviation. The most important thing is the normally what we know, the R in V1 is small than S. So here will be R is to S will be more than R will be more than S. Ulto have R will be more than S, and T wave will be inverted. So it will be known as the RVH with strain pattern. Now QT interval, the start of the Q, end of the T. QT interval ECG you should avoid. Now U wave. U wave is the wave that is present after T wave, and usually present V2 to V4. Mostly it is found in hypokalemia, can also be present in hypercalcemia, hyotoxicosis, exposure to digitalis. If in a normal U wave are very small, round and symmetrical, and positive in lead 2, it is in the same direction towards the T wave. T wave যেদিকে U wave সেদিকে usually পাওয়া যায় না, তবে mostly hypokalemia, hypercalcemia এইসবগুলোতে পাওয়া যেতে পারে, and inverted U wave may represent the myocardial ischemia or LV volume overload. Another ECG sign for hyperkalemia. The hyperkalemia, the P wave will be narrow, tall T wave, which is an early sign. PR interval gradually becomes prolonged, and P wave loses amplitude. P wave height ta kome jabe, PR interval will be prolonged, T wave will be tall and peaked. So three important things: amplitude of P wave kome jabe, PR interval will be increased, and tall peaked T wave that is usually seen is hyperkalemia. But when hyperkalemia is very severe, then totally this is known as the sine wave pattern. That is like a wave, ঢেউয়ের মতো. So this is sine wave pattern is seen in hyperkalemia, severe hyperkalemia. For hypokalemia, opposite হবে, T wave টা flat হয়ে যাবে, and PR prominent, there will be presence of prominent U wave, and ST segmented depression হতে পারে. And for hypercalcemia, the QT interval will be short, and hypocalcemia QT interval will be prolonged. Pulmonary embolism, most important sign is sinus tachycardia. Right axis deviation may be there, incomplete RVV is there. There is an important sign known as the S1Q3T3. That is, normally there is no S wave in lead 1. So there will be presence of S wave, and there will be Q wave in lead 3, and also the T wave will be inverted in lead 3. This is usually S1Q3 sign. Most common sign is sinus tachycardia. Thank you.